because the foot is easy to blame on bad shoes or a long day. If you want health information explained in plain language with no guesswork and no drama, subscribe right now and hit like. The goal for Dr. Zach is 1,000 subscribers, and every single one of you moves that number. Today, I am walking you through 6 signs your feet are already showing you, what they look like, what is actually happening inside your body each time, and what you need to do about it. Before we get into the 6 signs, I need you to understand one thing about anatomy, because it changes how seriously you take everything that follows. Your feet sit at the end of the longest blood vessel highways in your body. To reach your toes, blood has to travel from your heart down through the aorta, branch into the iliac arteries in your pelvis, continue down the femoral artery in your thigh, through the popliteal behind your knee, split again into the tibial arteries of the lower leg, and finally reach the tiny vessels of the foot and toes. That is a long journey through a lot of territory. Here is what that means clinically. When the pressure in that system drops, when vessels narrow due to plaque, when nerve signals get disrupted by chronic high blood sugar, or when inflammation starts eating at the vessel walls, the foot loses supply before any other body part does. It is the last to receive and the first to suffer. This is not a foot problem. This is a whole body problem that your foot is showing you first. That distinction matters enormously, because treating it like a foot problem means you will keep missing the point until something serious happens. Now let's go through the 6 signs. Sign number 1, one foot or ankle that swells, the other stays normal. Most people accept swelling in the legs as a consequence of being on their feet all day. They prop their legs up at night, it goes down by morning, and they move on. Here is what changes everything. Swelling that affects both legs more or less equally can have benign causes: prolonged standing, heat, mild venous insufficiency where the valves in your leg veins have weakened and allow blood to pool downward. That is worth monitoring but not an emergency. Swelling in one leg, only one foot, one ankle, one calf, while the other stays normal, is a completely different clinical picture. That asymmetry is the alarm. One of the most dangerous causes is deep vein thrombosis, or DVT, a clot forming inside one of the deep veins of the leg. The vessel becomes partially or fully blocked, blood cannot return to the heart efficiently, and the leg swells from the inside out. You may also notice the area feels warm to the touch and tender when you press along the back of the calf. Why does this matter beyond the leg itself? Because a DVT clot can break off, travel through the venous system, reach the heart, and then get pumped directly into the lung arteries. That is a pulmonary embolism, a blocked lung vessel, and it kills people, suddenly, without warning. In some cases, the first noticeable symptom of the DVT was the slight swelling in one ankle that the person brushed off for 2 weeks. Unilateral swelling, one side only, especially if accompanied by warmth or calf tenderness, requires same-day evaluation. That is not a wait-and-see situation. Sign number 2, burning, tingling, or numbness in both feet, especially at night. This is the sign I see most consistently missed. Patients describe it as pins and needles that come and go, a burning sensation across the bottom of the foot, or a feeling like their feet are wrapped in thick cotton. It is often worse at night when they are lying still. They usually blame poor circulation from sitting too long, or they write it off as nerve compression from sitting cross-legged. And so they wait. Some wait for years. What this pattern, bilateral foot tingling, worse at rest, worse at night, very often represents is peripheral neuropathy. And the most common cause of peripheral neuropathy in adults is chronically elevated blood sugar. Here is the mechanism. Your nerve fibers are coated in a fatty protective sheath called myelin. The nerves that travel the longest distances in your body, the ones reaching your feet, are the most metabolically demanding and the most vulnerable. When blood glucose stays elevated, even in the pre-diabetic range, it triggers a chemical process that essentially starves and damages those nerve endings from the inside out. The longest nerves go first. That is why the feet are involved before the hands in diabetic neuropathy. It follows length. The dangerous part is not just the discomfort. When sensation in the foot is lost, cuts, blisters, and pressure wounds go unnoticed. They do not hurt the way they should. They get infected. They do not heal properly because the blood supply is also compromised. This is the pathway that leads to diabetic foot ulcers and, in severe cases, to amputation. If you have tingling or numbness in both feet and you have never had your fasting glucose or your HbA1c tested, that is a conversation you need to have with your doctor this week. Sign number 3, feet that are cold when the rest of you is not cold. Feet in a cold room is not what I am talking about. I am talking about feet that feel cold to the touch at normal room temperature. Feet that stay cold even under blankets. Feet where the skin looks slightly pale or has a bluish tint at the toes. This pattern points to a condition called peripheral arterial disease, or PAD. It means the arteries supplying your legs and feet have been narrowed by atherosclerosis, the same plaque-building process that causes heart attacks, to the point where blood flow to the lower extremities is significantly reduced. To understand how serious this is, consider that PAD and coronary artery disease share the same root cause. If your leg arteries are narrowed by plaque, there is a high probability your heart arteries are also narrowed. Studies show that people with PAD have a significantly elevated risk of heart attack and stroke. The foot is showing you the condition of your entire arterial tree. There is another clinical detail that matters. Look at the lower leg and feet. In PAD, patients often notice that the hair on the lower leg and foot stops growing. Leg hair requires healthy blood flow. When circulation drops below a threshold, the hair follicles do not receive enough oxygen and nutrients to sustain growth, so they stop. The leg becomes smooth and hairless below the knee. That is not just cosmetic, it is a circulation marker. If your feet are persistently cold and pale, and the lower leg hair has thinned or disappeared on one or both sides, tell your doctor specifically about those two findings together. Sign number 4, a wound on the foot that will not heal. Normal skin heals. A cut or blister on a healthy foot closes within a week to 10 days. That is the baseline. When a wound on the foot is still open after 2 to 3 weeks or worse, when it does not hurt the way it should given how it looks, that combination of slow healing and reduced pain sensation is a serious warning that two systems have already been compromised simultaneously: blood supply and nerve function. This is the clinical picture of a diabetic foot ulcer, and it is one of the most underestimated emergencies in primary care. The reason it progresses so silently is that nerve damage has already blunted the pain signal. The patient does not feel the urgency because the foot is not screaming at them the way it should be. Meanwhile, the reduced blood flow means the immune cells and oxygen that healthy tissue needs to fight infection cannot reach the wound in sufficient quantities. Bacteria take hold. The infection deepens into tissue layers that cannot defend themselves. What started as a blister under an ill-fitting shoe becomes a wound that reaches bone. Osteomyelitis, bone infection, is extremely difficult to treat. In many cases, by the time a patient reaches a specialist, the only option that prevents the infection from spreading further is surgical removal of the affected tissue. Every year in the United States alone, roughly 130,000 lower limb amputations occur, and the majority are related to diabetic foot complications that started as small, painless, ignored wounds. A wound that has not closed in 2 to 3 weeks needs to be seen by a doctor, not next month. Sign number 5, changes in toenail color, thickness, or texture. I want to be precise here because not every toenail change carries the same weight. Thickened, yellow, crumbling toenails in an otherwise healthy person often represent onychomycosis, a fungal infection of the nail. It is extremely common, not dangerous, and treatable. But it does deserve attention because a fungal nail is a breach in the normal protective barrier of the foot, and in someone with compromised circulation or blood sugar, even a fungal nail becomes a portal for secondary bacterial infection. What carries a much more urgent message is a dark streak, brown or black, running vertically through the nail plate. The medical term for this is melanonychia. In most cases, it is benign, caused by trauma or ethnic nail pigmentation. But in some cases, it represents subungual melanoma, a melanoma growing underneath the toenail. Subungual melanoma is one of the most consistently misdiagnosed cancers in primary care. It is often mistaken for a bruise. The difference is that a bruise from trauma grows out with the nail over weeks. A dark streak from melanoma stays fixed. It does not move. It does not fade. It may widen at the base where the nail meets the skin, and the surrounding tissue may become irregular. The rule I give my patients is simple. If a dark streak under a nail appeared without obvious trauma, has been there for more than 6 weeks without moving upward with nail growth, it needs a dermatologist's eyes. Not because it is definitely something dangerous, but because the one time it is, the window for treatment is everything. Sign number 6, leg pain that starts when you walk and stops when you rest. This is the sign that is almost textbook specific for one diagnosis, and yet it gets dismissed constantly as muscle fatigue or aging. The pattern is this. You are walking at a normal pace, and after a predictable distance, maybe half a block, maybe 2 blocks, a cramping, aching, or heavy pain develops in the calf, the thigh, or the buttock. You stop and rest for 1 to 2 minutes, the pain completely resolves, you walk again, and after the same distance, it returns. Physicians call this intermittent claudication. It is caused by peripheral arterial disease, narrowed leg arteries cutting off the blood supply below the blockage precisely when the muscles demand more of it during activity. At rest, the narrow vessel provides just enough blood to keep the tissue alive. The moment you start walking and muscles need 3 to 4 times more oxygen and glucose, the narrowed artery cannot meet the demand. The muscle essentially cramps from lack of fuel. When you stop, demand drops, the narrow vessel catches up, and the pain fades. This pattern is almost diagnostic on its own. What it tells you is that the arterial narrowing is already hemodynamically significant, meaning severe enough to restrict actual blood delivery. In cardiology terms, the equivalent of this in the heart arteries is angina, chest pain on exertion that resolves with rest. Most people take angina very seriously. Intermittent claudication in the legs deserves the same urgency because it often precedes the same endpoint. Here is exactly what to do after watching this video. First, take your socks off right now and look at your feet. Check both sides for swelling, color differences, wounds, nail changes, and hair distribution on the lower leg. This takes 2 minutes and costs nothing. Second, if you have tingling, numbness, or burning in both feet that has been present for more than a few weeks, ask your doctor for a fasting glucose and an HbA1c. The HbA1c reflects your average blood sugar over the past 3 months. It cannot be gamed with one good meal before the blood draw. That is the test that catches the pre-diabetic range where nerve damage is already beginning. Third, if your feet are persistently cold and pale and the lower leg hair has thinned, ask your doctor about an ankle brachial index test, a simple, non-invasive pressure measurement that compares blood pressure in the ankle to the arm and tells you how well blood is reaching your feet. It takes about 10 minutes and can reveal significant arterial disease that has no other obvious symptoms yet. Fourth, if you have leg pain that follows the exertion-rest relief pattern I described, do not accept it is just aging as an answer. Describe the pattern precisely. Same distance, same pain, resolves with rest. That description alone should prompt a vascular workup. Your feet are not separate from your heart, your arteries, your nervous system, or your blood sugar. They are the end of all of those systems, and they are telling you what is happening long before a blood test or a scan finds it. One-sided swelling, tingling or numbness in both feet, cold feet with no leg hair, a wound that will not close, nail color changes that do not resolve, and leg pain that follows the walk-stop-relief pattern. Any one of these is a reason to talk to your doctor. Not eventually, specifically, and soon. Everything covered in this video is for your understanding and education. Your individual situation is specific to you, and this is a starting point for a real conversation with your physician, not a substitute for one. If this video made something complicated feel clear, subscribe to Dr. Zach and leave a like. That is how we reach more people before the window closes.